All right. Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller, and today we have Dr. Chhaya Makhija. Welcome to the podcast. How are you?
Thank you. Thank you, Dr. Reller. I am doing great and very excited to listen to your questions and share some tidbits in the hormonal world.
Yeah. So, why don't you tell our listeners a little bit about who you are and what you do?
Sure. So I am Dr. Chhaya Makhija. I'm a triple board certified physician. So endocrinologist and lifestyle medicine are my big specialties that I provide care to for my patients in the state of California. And my practice is called Unified Endocrine and Diabetes Care, which is a direct specialty care. And to simplify, it's like a boutique concierge care for our patients in California. My goal, mission is prevention. So prevention of chronic
Mhm.
diseases and simplifying complex hormonal questions and diseases. So it could be thyroid, it could be any form of the hormone in our body, as well as prevention, which is prevention of diabetes, prevention of obesity related conditions, as well as prevention of osteoporosis and low bone density. And we focus on like the time, access, building that trust and, the mission for patients, and I'm sure when they come and get into the door is also that, can I experience a transformation? So that's always, a big win for the patient and for me and my team when we're dealing with our patients as well as the community. The other part is my fun part or aspect of it, which is like lifestyle medicine, which is beyond exam room, beyond my practice, which is engaging in the community. So we have these events where we practice laughter, breath work, as well as, walking, moving, workouts, using bands, or how to incorporate physical activity no matter how busy we are. So that's my fun profession that I can call, which has been inspired a lot by, learning more about lifestyle medicine and also my other tying both endocrinology and lifestyle medicine, but still connecting to the patient is what is a part of the love that you have in medicine, and that's what I do.
Mhm. Yeah, that's a beautiful combination of the endocrinology aspect, like the medical aspect, and everything that you learn in lifestyle. And obviously, like you mentioned, like your upbringing and everything. So it's so nice that you're able to do all of these things and wear all of these hats. That's wonderful. I was going to say, where I know you're trying to put a lot of good information out there too. And I always ask people at the end. So I'll ask, like, where can they find you? But you are, doing the kind of something similar. Like, I think you mentioned you had a podcast and you're putting good information about hormone health out into the
Mm-hmm.
community as well, right?
Mm-hmm. Yes,
Yeah.
in today's era, it's not just Google or Chat GPT, and as we are rapidly progressing with AI,
Mhm.
our patients, our community, and ourselves too, right? We're bombarded with information. And if someone can simplify it, and someone has to be an expert that I can trust, right, as a
Mhm.
patient. And that's been one of the decisions that I made, that instead of just having this exam room Q&A with patients and trying to draw diagrams or give them a pictorial representation of, you don't have this versus let's work this up for a symptom or hormonal issue. I've had my medical students participate with me to create handouts, to create guides which simplify, the hormonal question, the metabolic questions. And then they are the ones who inspired me that, Makhija, why don't you just start a podcast, which is called Hormones and
Oh,
Hope.
nice.
And the name was decided by them. They figured it out and they decided what it's going to be. And then that's how I started interviewing a lot of physicians throughout the country. And now it's physicians who are practicing internationally, who are providing their expertise and their way of breaking science into simplification for our patients and community. So thank you for
That's
asking about
awesome.
the
Yeah.
podcast.
And you should also mention that you are teaching, right, in the community as
Correct.
well.
Yeah.
Yeah. Yeah. So it's,
Yes. That's the beauty of education. So it's not limited to patients, our
mhm,
community, but
mhm.
also to our near future physicians.
Nice. Well, I was going to ask you all about thyroid truths today. So, where
Yes.
do you think we should begin, and why does thyroid health matter for general wellness, energy, metabolism, weight, everything? So, what's so important about the thyroid?
Sure. So thyroid is, first where it's in our neck, and it's an endocrine gland, meaning it's producing hormones, which is one of the essential hormones for our sustenance. So we need insulin, we need cortisol, and we need thyroid hormone, without which we cannot sustain life. So that's why thyroid is one of those essential ones for our life in general, right? Just to understand that. And it's a cute structure. It's situated in the neck, the lower part. It has two wings, which is right and left lobe, and a connector called as isthmus. The entire gland is producing, hormones. And I'll specifically just relate to thyroid, which is T4 and T3. And, people should at least know that our thyroid hormone is different than animal thyroid hormone. And this we may cover in, supplements or myths or benefits by taking right supplements versus just incorrect supplements, which might affect our health negative. So we produce around 80-85%. We, meaning the thyroid gland, produces 80-85% of the T4, which is also called as thyroxine hormone. And then the rest is T3, which is less in terms of production by the thyroid gland. Now, why is that? Is because your body or our body, every cell knows how much thyroid hormone I need for my machinery. So we have trillions of cells, and each cell is an engine. And each cell needs glucose. It needs, one of the aspects is the thyroid hormone. So when the T4, that's the most available hormone, it circulates in the blood. It goes to, say, your heart cell, your brain cell, or your muscle cell. And the cell demands that, okay, I need some active thyroid hormone. T4 enters into it. It gets converted into T3, which is your active hormone, which is producing actions. And that's why the cell decides how much T3 I need. So we should, that's a very common conversation that I have with patients just to understand what thyroid hormone is and how is it divided into the chemical structure. We need iodine to manufacture thyroid hormone, and that's why you'll start listening or hearing about iodine supplements or prenatal supplements, which with more iodine and iodine deficiency. So that's also connected to the thyroid hormone. The other micronutrient is selenium, which is also in very, very minor portions, like literally very teeny tiny portions, is needed. And it's a micronutrient, that is micro amounts for the synthesis of the thyroid hormone in it. Now, you asked about metabolism or how it's helping our body, right, function. So it's not limited to just the engine part of it, that it helps our engine, cellular engine, as well as our, the entire organ systems to run at a specific speed. But it's not the sole hormone to determine metabolism. We have lots of other hormones, glucose governing it, and also, various pathways that help each engine run effectively. So imagine if you're in harmony or your thyroid hormone is working in sync with what your body needs are, you're more into called as a euthyroid phase, or the labs will be called as euthyroid. And then we can dive into, what's the grayscale. So we have a large spectrum of thyroid conditions. It's not as simple as black and white. And that's why I feel like, going to a physician rather than, false claiming hormone expert is very essential.
Wow, that was a lot and great explanation of what it does like in the normal state, right? So I guess since you're, expert in this, what are some of the people are coming to you for when they think something is off? And why might that be that they think the thyroid is off? And we'll talk about obviously the common thyroid conditions, but
Sure.
yeah.
Yes. Yeah, that's a great question actually, because, with one of the common symptoms, which I'm pretty sure you as, a physician, you're seeing patients so frequently, and of course doing the annual, is fatigue, right?
Mm-hmm.
And that could range from a kid to an elderly. The age spectrum is also wide, but most of the individuals in today's era will still search for why am I tired? And your Google ChatGPT AI answers will be that check your thyroid hormone. And the next thing is check your thyroid hormone. Thyroid looks normal on the blood test, but it still may be a problem. Now that's the outside world, external world. And now I'll share, what is evidence-based and also what's the clinical experience, right? Because everything is not medical textbook as we deal with real humans and real patients. So common symptoms would be, fatigue, palpitations, weight gain, and sleep disturbances that patients will come to me with. And these are symptoms. You're not asking me to look at just the thyroid, but these symptoms can they be connected because I have a thyroid disease. The other ones very commonly are my doctor said my antibodies are high, and they don't know which antibodies, but my antibodies are high, or I have too much inflammation. Again, the inflammation is coming from the markers in the blood test. The third thing is, my thyroid levels are just off, but my doctor says, or my mid-level provider says that we can watch and wait. So what do you think as a second opinion? The fourth aspect is our women, right? So when they are trying to conceive or they're not having regular cycles, and when I say not having regular cycles, it could be anything. No cycles, heavy periods, or lack of periods. It's called oligomenorrhea, amenorrhea. Same thing. Is thyroid a problem, right? And then comes palpitations, weight loss, overdrive, like your system is on overdrive, which is palpitations, tremors, excess loose stools. So these are common scenarios where patients will seek out, care. It could be their physicians. It doesn't have to be an endocrinologist, but because I don't have any requirement for referrals, I end up seeing these patients as well before they've seen their primary care physicians. The other aspect, which is also an important aspect of thyroid, is my thyroid is big, or I feel a lump in my neck. And, usually the most common scenario is the patients will just point at the neck. It could be the right side of the neck, it could be left side of the neck, it could be the central part of the neck, but they think everything in the neck is thyroid. So they're concerned that do I have a thyroid mass or a lump? And then, of course, referrals coming from physicians that there was an incidental thyroid nodule discovered on carotid ultrasound. What do we do next? And very commonly which is important, is incidental findings. Just because we had a lab screening, annual screening, especially in patients with perimenopause and menopause, they may have some drift in their thyroid hormone levels. And I'm being very specific for TSH, the thyroid stimulating hormone. And that's where they are in this dilemma of, should I treat it? Should I watch it? Versus should I try hormone replacement therapy because I have symptoms? Are my cycles regular because of perimenopause, or is it the thyroid? So now it gets into more complexities. Yeah, so I'm giving you just a common layout of the common thyroid diseases. I don't think we need to go into thyroid cancer as such. I think this is more a hormonal issue.
Yeah, no, I agree. I think you gave a great outline of all the things that, I think that are important and that you would see rather than thyroid cancer. And you've mentioned the thyroid nodules and stuff and why a doctor might have sent you there. But you're right, given your type of practice, like people are going to pursue, a second opinion or education on these symptoms that they're having. Yeah. So the thyroid is, a super important gland, organ, endocrine system, as you were saying. So when they come to you and you're, trying to work them up, what labs do you do, obviously, and sometimes I guess why sometimes is just the TSH kind of not enough?
Sure. Again, a very good question that comes around. I'm pretty sure your patients ask you a lot too. Can you get me tested like a thyroid panel or full thyroid panel rather than just one? Yes. So I feel like, we should be, it's not necessarily thinking out of the box, but if as a physician, right, whatever labs we are ordering, if you're confident we know how to interpret it, then it's very valuable for the patient, right? So as per our guidelines, most of them will suggest that if you're doing a screening annual test for a male or a female, they don't have any symptoms, just do a TSH, which is thyroid stimulating hormone, being synthesized or produced by a pituitary, which is right behind the midsection of our eyebrows and underneath the brain. And it's a signaling hormone. It's not an actual thyroid hormone, which is active. All right. So based on that, they decide that, if it's abnormal, then we'll do the rest, which is T4 and T3. When I'm screening patients, I prefer getting all of them because I know how to interpret. I'll tell you some scenarios. So TSH, T4, T3. TSH is, in sync, T4, T3 vary a lot. So if a physician knows how to interpret it, it's based on also the half-life and what are the patient's symptoms, what medications they're exposed to, if they're taking any form of supplements. Like, biotin is a very common culprit to mess with the TSH assay, like the machine itself. The T4, T3 also varies. So 3 levels in someone who is healthy, not pregnant, and not on any form of hormones like estrogen, progesterone, or any estrogen, or no birth control pills, not in a postpartum period, and they don't have any liver disease as such, then, you can rely on the free T4 and less reliable free T3. But, over time, you get to know that what T3 ranges are and why it could be very, very valuable. I'm talking about screening and not anyone with symptoms, but your decision will mostly be based on TSH and free T4. Asymptomatic person. Now, when they are symptomatic or you're not sure, why this person has a specific symptom like weight gain or fatigue, then I would, get these three evaluations done. But in many cases, if they have a larger thyroid gland, or if it feels irregular, or if they have a strong family history of autoimmune conditions, or especially if that patient is a female, it's worth getting the TPO antibodies, not to scare the patient, but it just guides us that if that test is abnormal, and especially when they have symptoms, why waste another time slot for the patient to get a separate blood draw, right? So you're getting the thyroid hormone levels and you know how to interpret the TPO antibodies because you're suspecting hypothyroidism or subclinical hypothyroidism, and that gets very valuable. Nowadays, we also have thyroglobulin antibodies. But like I said, if that physician knows how to interpret it and alleviate the patient's anxiety and fear, then go ahead and do it. It will be valuable in terms of like supporting the diagnosis of the subclinical or primary hypothyroidism and just guide them with that treatment. Now comes the other extreme, which is hyperthyroidism, too much. In those scenarios, you have to, if you have a diagnosis or if you're suspecting that the patient might have it, then you want to get all three of them, TSH 3 to 4, 3 to 3, and then the specific antibodies for that condition, which is called Graves' disease, would be very, very essential to help with. We also see thyroglobulin and antithyroid antibodies. But truly speaking, like no matter if you get it, if it's elevated, if we have a functioning thyroid, we're supposed to have elevated thyroglobulin because it's a protein. It's being produced by the thyroid gland. So in a functioning thyroid gland, you don't need to get thyroglobulin. The only reason we get it is when patients have thyroid cancer diagnosis, they're going to get a surgery. So it helps us to use that as a marker, like literally like a cancer marker to follow up them in the near future post-surgery. Similarly, antithyroglobulin antibody goes along with the thyroglobulin level. If you have a question, I can share some of the, evidence or insights on reverse T3 because I get that as a very common question, but I would leave that up.
Well, so you were mentioning previously something about evidence-based versus the clinical patient. So I was going to ask you, so if you order all of these things, is this something that is covered by insurance, or is it just the evidence-based things that are covered by insurance? And otherwise, what do you do? And maybe where does that reverse T3 come in?
Yeah. So all the tests that I talked about, it's usually covered by the health insurance because, you have to put a specific diagnosis, symptoms, add fatigue, add weight gain, add condition, or there is a thyroid disorder code that we have. So definitely then that's very valuable. I don't support getting free T3 for everyone if they're not having symptoms because it's just, it is more expensive than TSH and free T4. But like I said, it depends on the physician's interpretation. If they're confident, then go ahead, but not to use it as a sole test for diagnosis of the condition called hypothyroidism or subclinical hypothyroidism. With evidence-based, right, clinical interpretation, one thing I'll point out, which is very essential, that our body knows how to maintain harmony. And thyroid gland is one of them, which is I would say a very cool organ to adapt to situations. So say if, a human or a patient is in the hospital or going through a major stress like fracture, major sepsis, infection, urinary tract infection, there is a condition called sick euthyroid syndrome, which basically in simple language or explanation that I can tell you is your pituitary is telling your thyroid, but don't work too hard because I need to heal my fracture, or I need to recover from this urinary tract infection, or, I have an eating disorder, so I need to focus on saving my calories. So don't work too hard. That's a protective mechanism. So in those scenarios, we might see a mild elevation in TSH, or many times we'll see a low free T3. Okay, and that is more of an adaptive mechanism if we are getting into the clinical history when we're discussing with the patient. And I don't pamper the thyroid's response, which is appropriate in those scenarios. You can wait for 4 to 6 weeks. When you know that there is an obvious scenario, which is appearing like sick euthyroid syndrome. In those cases, academically, we can use reverse T3 because that active T3 is being converted into reverse T3 because, the body is telling the thyroid hormone that I don't need too much active thyroid hormone right now. I need to give my other cells rest. It's not that they're not functioning. It's just slower because I need to heal this type of an organ system, or I need to heal the eating disorder in terms of the caloric intake. I need to make sure I match it. But this was only done in academia. Like, when you're teaching students, residents, we tell them that, okay, if you want to order reverse T3, go ahead, because this will just re-emphasize the fact that whatever we are discussing clinically is actually making sense biochemically. But do you need to get that when you're an experienced physician? Not really, because you know what's going to happen.
Mhm.
And then focus on the patient's recovery or treatment. In very cases, I see psychiatrists using T3 hormone in these patients with eating disorder, depression, anxiety, and they have some literature on that, but I leave that up to psychiatrists because they're really trying to treat the patient overall in terms of their mental health. So that's a very complex situation if for the patient, I would say, because it's very difficult for them to understand the negative, positive feedback, or what is acute thyroid and how is the complexity of this hormonal cycle to seek harmony or to seek homeostasis is being maintained. So those are the scenarios where, where reverse T3 actually came into play for biochemical orders or for lab orders. And then how do we use it clinically? It is an expensive test. But, do I need it as an endocrinologist? Not really. I haven't ordered reverse T3 even once in my clinical practice. Now, patients bring me their labs where they've ordered reverse T3 by some other, lab or physician or, the healthcare professional that they're following. But otherwise, I help them interpret and then help them make sense out of it. But it really doesn't help me to help the patient.
How about, well, that's definitely more of a, I don't want to say unique case, but maybe a little bit rare. What about with
Yeah.
something a little more common like Hashimoto's thyroiditis? And how can you
Mhm.
differentiate that from like other hypothyroidism?
Sure, yes. Yeah, that's again a very, very great question for thyroid, a very highly searched terminology and
Yeah.
condition. So Hashimoto's is the Japanese scientist who discovered TPO antibodies, that's the thyroid peroxidase antibodies. And many of us now know that antibodies are basically attackers, proteins that don't let your thyroid hormone synthesize in a normal manner or what your thyroid is supposed to do. And when it overtakes the thyroid hormone synthesis, the autoimmune condition, it can lead to underactive thyroid. And that's where the gray spectrum is. Someone could be just mildly hypothyroid based on, their symptoms. And of course, the TSH doesn't determine if it's mild, moderate. It's a lot to do with symptoms and what their matching CT4 is saying. But there's also something called a subclinical, where TSH may appear to be high. That is, the pituitary gland is really trying to push the thyroid that, hey, I am not getting enough thyroid hormone. I'll give you some boost. Can you just make adequate? And the thyroid responds. It makes adequate thyroid hormone, but the pituitary signal is working harder. That's a subclinical scenario. So when we have anti-PO antibodies and now even thyroglobulin antibodies, to support that the thyroid gland is working harder than it is supposed to, we term it as Hashimoto's disease, and Hashimoto's is more specific to anti-TPO or TPO, thyroid peroxidase antibodies. Now, if anyone has Hashimoto's, that is presence of antibodies, does that mean that they have hypothyroidism? No. So hypothyroidism or subclinical, you still have to get those three tests, or at least TSH-BT4, to figure out where you're at the spectrum for TSH. If someone has symptoms and the TSH is mildly elevated, but still not abnormal, like say not greater than 4.2 or so, and if they're very symptomatic and all other causes have been ruled out, like especially in medicine, like you look at, fatigue or weight gain, then supporting it with a trial of thyroid hormone clinically makes sense, but that is more of a physician shared decision making.
Sorry, do you mean that they
Yeah.
have an elevated thyroid
T
peroxidase antibodies, but normal TSH? Is that what you
high.
were
So
saying?
if the
So high
TSH
TSH. Okay.
is, close to 4.2 or getting closer to
Mm-hmm.
5 and they're
Trace.
symptomatic, yeah, so, a
Mm-hmm.
low dose of 12.5 or 25 micrograms of levothyroxine, try it for
Mm-hmm.
30 days. It helps, great. It's not messing with your thyroid hormone production. If it doesn't help, it's very convincing for the patient that, okay, let me look at what other things are causing my
Mm-hmm.
symptoms with their physician. But
Mm-hmm.
it will not cause harm per se if you ruled out every other scenario that can cause their symptoms, and especially in patients with, again, perimenopause, menopause, because there is this fluctuation happening. We have guidelines for patients with infertility. So I'm getting more to talking about women, infertility, preconception period, and they have TPO antibodies and their TSH is greater than 3, total is 2.5, but greater than 3, you should be able to give them levothyroxine. Their TSH is less than 2.5. And the main reason is once it's shown that it can help with the success of IVF if they're going through that. And also, just the physiology that the fetus, when it's growing, the first 16 weeks, it needs the maternal thyroid hormone. So if the maternal thyroid hormone is fluctuating, that's based on the TSH and high TPO antibodies, then you're actually helping the fetal thyroid hormone or the fetus to receive enough thyroid hormone during that first 16 weeks, supplementing the mother with a low dose.
What happens? Well, that's very good information from the fertility perspective. But going back to the TPO, but what if someone has elevated thyroid antibodies but normal CSHT4? What kind of things should they be concerned about? What is the potential there?
Right. So when you say thyroid antibodies, I suppose because that's the most one. So the Hashimoto. So it's still autoimmune. So we have an autoimmune. There is likely a strong family history or, scattered family history of autoimmune conditions, which are multiple, which are like in hundreds. It could be rheumatoid arthritis, it could be lupus, it could be type 1 diabetes, it could be vitiligo, like white patches. These are all autoimmune conditions. And, your siblings and family, if they're dealing with any of these inflammatory bowel disease, ulcerative colitis, Crohn's, and then we inherit those that I'm blanking on the word, but we inherit the autoimmunity aspect of it. So we can produce those antibodies. The most common ones for female is the TPO antibody. So in general, thyroid disorders are more common in women than men. So we do see that, there will be elevations in the TPO antibodies despite having a normal TSH T4, and they probably may not have symptoms or they may have symptoms and suddenly we look at TPO antibodies, oh my gosh, it's elevated, what do I do? Is that causing my symptom? Most of the times it's not causing the symptom if your TSH is excellent. So, 2, 2.5, 3, and your free T4 looks robust and you have this elevation in TPO antibody, it predicts that you have a risk of developing subclinical or clinical hypothyroidism in the near future. The last time I looked at percentages, it's between 3 to 5% risk of developing it, and it doesn't stack up every year. Elevated TPO antibodies and very good mid-normal range TSH T4. But if there could be some stressors, specifically in females, which we talked about, conception, preconception, postpartum period, they may have a higher incidence of thyroid. And thyroiditis could be too much thyroid hormone, and then it gets to a less thyroid hormone. Patients are quite symptomatic as much as, it's not an emergent condition, but they do get symptomatic when the thyroid hormone levels are fluctuating from high to low. And then comes perimenopause, menopause, age where they might have higher risk for developing hypothyroidism or hypos. So when do you treat it? It's like $1 million question for physicians, right?
Yeah.
And that's where when I, discussed about that if the TSH is 3.5 it's getting higher, you see that patients have symptoms, nothing else seems to be obvious, or you've corrected other disorders which could cause these symptoms and they're still, dealing with fatigue or dealing with that weight issues, then trying that 30-day trial and see how they respond is a very good way of, I would say, the patient-physician shared decision making. And in some patients, I see that they get an improvement with the low-dose levothyroxine. And that is just because, TPO antibodies are high. You cannot sit and check TSH every day. You cannot sit and check T4 every day. So, there could be fluctuations and variations that they may need that extra supplementation clinically. That's where, we decide. But again, you want to follow up those patients to see if they're actually benefiting rather than giving them an annual prescription for it.
And did you say 3 to 5% end up? Okay.
Like the risk. If they have very good thyroid hormone levels, the TSH T4, mid-normal range, and the TPO antibodies are elevated.
Okay. Yeah. Are there any myths about, thyroid care or misconceptions that are, pretty common that you would like to dispel?
Yes, a lot. All right. So on top of my head is, I'm tired and it's always going to be my thyroid. because, more common ones is, especially in females, that's usually, looking at our sleep and of course what we eat. And that dictates a lot onto what our metabolism, our energy levels are doing. So that's why every fatigue is not thyroid, every weight gain is not thyroid. But yes, you can rule it out. But most of the times you'll see that it's not necessarily always the case. So always look at multiple aspects, especially for patients who are listening at the audience, that don't just limit to thyroid. The other one is every lump in my neck is thyroid cancer, and then I'll tell you the third, which is also relevant. But what we need to remember, we have like hundreds and hundreds of lymph nodes in our neck on the right and left. And then comes the thyroid gland. So most commonly, the lumps are usually related to lymph nodes. We get dental infection, we can get eye infection, we can get ear infection, and lymph nodes actually enlarge to protect us from those infections. So it's basically our immunity, which is working, or it's in action at that time. The third one is every thyroid nodule is thyroid cancer. Again, the risk of thyroid cancer in every nodule is very, very, very low. I actually have a YouTube video with one of the, California's endocrine surgeon, thyroid surgeon, where we debunk a lot of thyroid nodule myths and actually share what is the true incidence, how do you work them up and how do you alleviate your anxiety and fear about the word cancer. So every thyroid nodule is not thyroid cancer. Most of them are benign. And, the best thing is to get the right information and knowledge about your thyroid in terms of ultrasound imaging and getting that evaluated. The fourth one is animal thyroid hormone. So there are these thyroid supplements available online. Thyroid boost is very common. I have lots of pictures, thyroid power, and then, just thyroid supplement. So if anything's available over the counter, people, it's not going to boost your thyroid. The reason being, you look at the micro ingredients, most of the times I'll find that it'll have animal thyroid hormone, animal extract, and it definitely has some amount of thyroid hormone. And as females, as the mother, that's the only time that they'll need more iodine than what their daily multivitamin is. The second is selenium supplement, and the dose studied is around 200 micrograms that can help with reducing the TSH level and the TPO antibodies. And we don't have enough data for thyroglobulin antibodies, but in these patients with as a treatment, but it can support by adding, for me, I just make use of it 30 to 60 days, not beyond that. And this is usually for abnormal TSH, that's high TSH, mildly elevated, not in the hypothyroid numbers or range, and elevations in TPO antibodies, where it's supported in terms of what evidence we have for selenium. Brazil nut also contains a lot of selenium. Yes. Yeah. And, the only thing is one Brazil nut may vary. It may have 200, may have 150, may have 175. So what I do personally for my patients is if there is a specific individual with autoimmune thyroid disease, with Hashimoto's, either they're on levothyroxine replacement for their hypothyroidism or they are not, I may recommend to go on selenium supplement, 200 micrograms, no other ingredients, for 30 to 60 days. Or in some patients who are in that, in the preconception phase, I may just tell them start, and they're not planning to conceive, but they're in the postpartum period. They still continue the prenatal because that has around 1% of iodine and some amount of selenium, probably 12 to 15 micrograms. But 200 is the dose, so take it for 30 to 60 days and then switch to a Brazil nut, so that, you're not sitting and worrying about, can there be a chance of selenium toxicity because that exists.
Yeah, I mean, I was going to bring up the Brazil nut. I think you only need like one of those a day, right?
Correct.
For your dose. Yeah.
Yeah, you're so right. Yeah.
Yeah. That's really always good information to have about the supplements. I think also with thyroid health, we sometimes hear some, I don't know, maybe previously people would give it for thyroid replacement, maybe even for like weight loss in a diagnosed hypothyroidism way. I don't know. Have you heard of this? Can you comment on that or anything?
So when you're not seeing a right board certified physician or, anyone who actual physician or of course the endocrinology, but beyond this, that's when I see these replacements happening. So there are adrenal extracts, there are thyroid extracts, and there are prescriptions for T3 And by the time I see the patients, they're either, dealing with anxiety or palpitations or just not feeling right. Or the fourth common one is I'm just tired of taking supplements and I still don't feel good, right? So patients are seeking out to feel good. And when they know that, oh, it's not a prescription, but it's going to be a supplement or it's going to be a low dose prescription, not knowing that it's an actual thyroid hormone, which has effects on our cells, and then eventually they get tired of it. So that's very essential because, thyroid, be it in animals, like a thyroid extract, or a prescription form, or you're taking a supplement which has animal extracts of thyroid hormone, is affecting your metabolism. It is bringing about some change. And the two most important organs are the heart. So the electrical activity is very sensitive to T3. T3 is more, or it's in terms of synthesis, like we talked about T4 and T3 in humans. In animals, they produce more T3. So if you're taking animal extracts, knowingly or unknowingly, that has more amounts of T3. And it will, most of the times cause this side effect or an effect on the heart, electrical activity. So arrhythmias, palpitations, feeling like there's a sense of anxiety, very common extra beats and PVCs, and they're taking supplements, and then you realize, oh, maybe this is the culprit, and they've gone through this entire cardiac workup. The second is bone. So, over time, more exposure to the thyroid hormone and not looking at the biochemical aspect of thyroid, which is your blood test. And if the TSH is kept low, because, like you said, right, because they're getting thyroid hormone for weight loss, or they're getting thyroid hormone to treat their fatigue, and their thyroid stimulating hormone is dipping down closer to zero, it will impact the bone because bones are also sensitive. So we lose more bone cells than what we do normally. So these two organs are very sensitive to too much thyroid hormone. And you could get too much thyroid hormone even like if you're getting a prescription for treatment versus too much of it versus an animal extracts supplements, which you, like I said, knowingly or unknowingly, you've been taking it.
Well, I feel like I've taken so much of your time and there's so much more we could discuss, but I don't want to not ask you about lifestyle, and thyroid health. So please give your recommendations on that. So how they can have the best
Yes.
as
Thank
quickly
you.
as you
Thank you
can.
for asking that. Yes.
Yeah.
So, if you had a patient or, if any of your audience is listening, if they have an actual condition which is undergoing treatment like hypothyroidism or hyper, so too much or too little, right? I would never advise that, oh yeah, go exercise or eat well to fix that problem. So pharmacologically, as a physician, you're treating those conditions just like you would. And simultaneously, when their condition is getting stable or they've started feeling their normal self, the most common endocrine autoimmune disease is thyroid. It could be Graves, it could be Hashimoto's. Hashimoto's is more common than Graves. So for the long term, right, that's where, our foods and our activity, anything that is anti-inflammatory, right? And it doesn't have to be going on again on an internet search and trying to look for anti-inflammatory diet, but anything that is mostly unprocessed or absolutely avoiding the ultra processed foods, which is anything in boxes and packages, cans. Your plant foods are very, very helpful. Turmeric as an anti-inflammatory effect has been studied well for, for arthritis, for MSK or musculoskeletal issues, but it doesn't harm to use that as an anti-inflammatory supplement if you're discussing with a physician and it seems right. Now, do I say that that will reduce your autoimmune thyroid disease? We don't have that in studies, but when we have autoimmunity, it's not just one aspect, right? We are producing attacker. There is inflammation in the body, so why not look at our foods and our physical activity towards it? I talked about two supplements, which is, the prenatal or if someone needs an iron supplement in females, and then the selenium. The other aspect is, what I see in my patients with Graves' disease. So when they are treated, this is hyperthyroidism, when they're treated and they're more in that remission phase, stressors, okay, and it could be physical stressors, it could be a demise at home or, losing a loved one, so stressors in life and not just the usual work stress, but, lack of sleep or worrying about something is shown to like trigger a relapse.
Mm.
right? So when they are getting better, stable, because they're very symptomatic when they're hyperthyroid and they're getting stable, that's when we start talk about or teach them about how to cope with these challenges. Breath work is very, very helpful
Mm.
because it stimulates our parasympathetic nervous system, the vagus nerve, which is the longest coming from your brain all the way going into your gut. And it's passing right through the neck. So it's helping with the heart rate. It's helping with the heart rate variability. And this is all science. It's not just me sharing, my
Mm.
experience. But that has helped them to cope with stressors, and then of course you are dealing with one less medical condition worrying about a relapse because you're able to cope with that stress with more strength and with more power and just more wisdom, so then it's not affecting your physical body or condition, which is Graves' disease. You'll also hear about avoiding Brussels sprouts, broccoli, cauliflower when you have hypothyroidism or Hashimoto's. That's only if there's like a lot of iodine deficiency and you're not treated for Hashimoto's thyroiditis or underactive thyroid hypothyroidism, which is autoimmune, then avoiding it daily is okay, but you can still incorporate that, several times a week. But not taking it for breakfast, lunch, and dinner, only broccoli and cauliflower or
I haven't
Brussels
heard this
sprouts.
one. Why is that?
What's that?
Why
They
do
called
they
us they
recommend?
called us goitrogens.
Okay.
Yeah, but that's a lot coming from our ancient data and more in the East Asian countries
Hmm.
where also there was iodine deficiency, and they call us goitrogens. Goiter is a large thyroid,
Okay.
so that but it doesn't mean that you have to avoid these foods completely because they have great benefits. Broccoli has been studied so well with its sulforaphane effects for anti-cancer activity.
Mhm.
So I would, it's basically like a myth. So you don't have to avoid these foods completely. It's just that weak rather than.
Mhm. Well, hopefully I don't get that because I eat a lot of broccoli. Yeah. Okay. What is there anything else you'd like to share with the listeners? Because I feel like we've done so much, and I know there's so much more that I would ask and cover, but I just feel like we're kind of out of time. But I don't
Yeah,
want to
no,
take more
this
of your
was
time.
great. You
Yeah.
actually covered, very important questions for the patients in general and also for, it's always getting the right expertise. We have the internet world today. And, me as a physician also, if I have a symptom or a pain in a joint, I may start looking for it, of course, the right resources and, maybe have a back or, the thought in the back of my mind that, okay, what if it is this? What if it is this? Right? You think about the worst possibilities first. But coming back to reality, coming back to the wisdom and knowledge, it's best to get your expertise rather than coming out with your own differential diagnosis based on
Mhm.
internet search and buying more worry and anxiety, because it just leads to more sense of worsening of symptoms or just more sense of doom rather than just
Mhm.
getting the right expertise. So, following doctors like you who are giving that information out on this internet and looking for right resources and right expertise will save you so much in terms of your mental health and your psychological well-being.
Yeah, very true. So speaking of that, where can people find you?
Sure, yes, you can find me on YouTube. I shared about the podcast. All the handles for Instagram, Facebook are at Chhaya. And my website is unifiedendocrinecare.com. And even if you search my name, I think those are the handles. And, very soon I am releasing like a global consultant, like a second opinion. So
Oh,
anyone, anywhere in the world can get a second opinion, without any prescriptions if they have these complex questions or complexities going on within their physical health that I would love to help them to.
nice, nice. We will put all that stuff in the show notes as well. Dr. Makhija, thank you so much for coming on the podcast today. And I hope everybody will follow you and listen to your, YouTube and podcast. And, thank you so much for joining me.
Yeah, thank you, Dr. Keller. You're doing amazing.
Likewise. Thank you. All right, everybody tune in next week.